the Robertsonian translocation that is in between two homologous, like 21-21, or 14-14, or 13-13, or 15-15, these are very rare, extremely rare, right? So if in a couple, one parent or one partner, being the mom or the father, has a translocation like that, in between both homologous, let's say 21-21, so this person actually has 46 chromosomes, but the homologous, the pair of 21, it's sticked head to head, right? So they will go always together in the germ cells. If it's a man, that gentleman will have spermatozoa with 2 chromosomes 21 and spermatozoas without chromosome 21. If it's a lady, she will have oocytes with 2 chromosomes 21 and oocytes without chromosome 21, right? It's almost impossible, didn't happen so far, that in a couple, both partners to have an identical homologous translocation, Robertsonian, on 21-21, or even 21-21 with 14-14, because these are extremely rare. They are happening in the cell division in ovogenesis or spermatogenesis, but extremely rare. So usually, and 99.9%, in a couple, only one partner is having a Robertsonian translocation, and the other has normal chromosomes in all pairs. They are separate, right? So if it's a couple like that, where when one partner, being the wife or the husband, it's having these 2 chromosomes 21 head to head, that means they have only 2 options, right? It's either they will have embryons who will be newly somic by chromosome 21. The chromosome 21 is missing. So this means immediately spontaneous miscarriage, because it's a chromosome, it's a full chromosome that it's missing. The genome of that nuclei says, oh my God, I have no chance to develop, it's better I die now. Or will be a trisomic embryo, where will be 3 chromosomes 21, in which 2 are coming sticked head to head from the parent who has it like that, and 1 is coming free from the parent who has it normal. So that person can have, it's either will be a trisomy, so again the genome is saying, I have too many chromosomes, I may not survive, it's better I go now. So can be a spontaneous miscarriage in the first trimester of pregnancy, generally before 10-12 weeks of gestation. But seems that in about 10-15% they can survive. And then if they will be born, they reach 9 months and they are born naturally, and they have Down syndrome. And will be a Down syndrome because a Robertsonian translocation between chromosomes 21-21 received like that from a parent. So if I go back to this family, where let's say the father, not necessarily the mom, the father has 21-21 head to head, this couple forever, either it's losing pregnancy as spontaneous miscarriages by newly of 21 or by trisomy of 21. And if a child is born alive, that child will have always Down syndrome. So therefore, the risk is 100%, because there is no alternative of a healthy child. You understood? Yeah. So it's almost impossible to have both parents with homologous Robertsonian translocation.
That
all right?
same applies
to 13-13, 21, yeah, 21-14 or 21-15. Or 13-13, 14-15. 15-15, it's very rare. 13-13 can be. But these are extremely rare. Therefore, I told you before, there are some states in United States where the premarital test that couples are doing before they marry, this kind of biochemical testing, viruses, HIV, and all this, it's including karyotype to rule out this kind of translocation that are actually devastating for the siblings or for the offsprings of these people, right? So now we didn't reach this level because the karyotype is expensive. That means the state needs to invest a lot of money to test all people of the marital age to see if they are balanced translocation or carrier of a balanced translocation or not, right? Clear?
Yes.
Other questions? For me or for Dr. Fouad or for Dr. Samira? For me or for me?
Can you repeat for us what is array CGH and the SNPs array?
Yeah. So CGH means comparative genomic hybridization. So you compare two genomes by hybridization. What means to hybridize? The DNA, it's double-stranded. A strand comes from the mom and a strand comes from the father, right? In order to test the DNA, you need to open the strands, right? And then you come inside with the DNA probe who is colored, who is binding to a strand. So then you decrease the temperature, and by hybridization, they will bind complementary, right? Comparative genomic hybridization means I have an array, it's a tool, it's a slide. So I have an array, a slide, where I put inside a genome that was already tested and proved that is normal. Nothing is missing, nothing is in plus. And that DNA, it's marked with a fluorochrome, red, let's say, right? So that's the normal one tested. Or if you want green, how it's easy for you to keep. Let's say the normal one, it's green, and the one to be tested, it's red. So on the slide, you already have a genome who is embedded there, right? And who is marked with green, old genome. Then you put the DNA of your patient who is marked with red. Yeah, you color it with the fluorochrome by hybridization. So then put it on the slide, you increase the temperature, and when you increase the temperature, the double strands will open on both the DNA of the patient and the DNA on the slide. And then when you decrease the temperature, they will bind by complementarity, one with each other. So if it is like that, if nothing is missing in the patient, you will see a combination in between red and green, that is orange or yellow. So on all small holes on the array slide, you will see yellow, and there will be a soft who is reading the color. If you will see too much green, means that there is something in plus, there is something in minus, right? Because it's missing from the patient. If you see something more in red, means it's something in plus from the patient. So in this way, you do deletion and duplication. That's the principle of comparative genomic hybridization. We started using this somewhere in beginning of 90s, and mainly we done this for cancers. Because in cancerous cells, in tumors, you have abnormal cell division and a lot of chromosomal aberration. So we use it in this way. Then, when the cytogenetics progressed, we used something like that when we suspected that patients may have structural chromosomal abnormalities, right? So in this way, we've been able to diagnose deletion or duplication in a patient with mental retardation, with different dysmorphisms that didn't look like Down syndrome or Patau syndrome or Cri-du-Chat, the classical ones, right? So if from the clinical signs and symptoms, you can say this is Down syndrome, or this is trisomy 13, or this is Cri-du-Chat, that's no need to go extensively to look to the entire genome. Comparative genome, you look to all chromosomes in one run, right? With the time, we upgraded the technology. Initially, we look at about, let's say, 50 megabases, and then we decrease it to 10 megabases. The technique improved. We've been able to create arrays who have much more holes inside. So instead of having a piece like that on a chromosome in each hole, I had a tiny, tiny piece, and even low, and even low, and even low. So we moved from the comparative genomic, just we compare this with this, to array, and to high density array or SNP array. High density means I increase the markers who are covering the chromosome. I cover them with a lot of, I mean, it's like you color a cartoon by dots till you feel the picture, right? Like that. So nowadays, we reach of the level called SNP array. SNP means single nucleotide polymorphism. Yeah, the one that you wanted to ask me about, right? Single nucleotide polymorphism means I have an array that inside I have markers for one nucleotide. I have such many holes that I have the DNA for one nucleotide. So then when I read it, I can assess a deletion or a duplication to a level of a nucleotide. Extremely, yeah, for even one, if one nucleotide is missing. This is the highest level. And we can use it now in rare monogenic disorders, or in this way, if you do it as a SNP array or high density array, you can extremely precisely mapping the breakpoint. So I can tell to a patient that your deletion, it's exactly from this nucleotide till this nucleotide. And what will be the advantage? Because nowadays, because we know the human genome, I know in each region, remember I showed you images, in each region I know which gene it is and which disease it's associated with. So if it's a deletion from here till here or from here till here, counts, because I will have more genes, so then I will have more symptoms and more severity. So if it's shorter, then at the level, I can know exactly which genes are there and I can predict a right prognosis. Right? And more than that, because if I know the break point, broke here and here, I can test in the parents, it may have a rearrangement, because I know exactly where it was broken. So I can come, you don't see translocation with arrays, no matter which level, even the simple one, even array, even SNP array. You don't see translocation. Will be colored where it's broken. And you know what is in plus and what is in minus, but you do not know if this deletion, that it's unbalanced, it's a result of something that it's balanced in the parents. You don't know that. So because you know the breakpoints, then you can go in the parents with FISH and mark exactly that region to see where it is, if it's somehow missed. Then you can identify translocation in parents. So therefore, it's so advanced now when we do microarray. And this microarray or high density or SNP array, it's also used in pre-implantation genetic diagnosis. So you can test embryos before they are transferred to uterus, and then you can rule out a lot of chromosomal abnormalities who are, again, not linked with age, right? Remember I told you with the weak points in the wall, right? And the chromosomes. Clear?
We have SNPs. We have other definition for SNPs.
There is only one definition, single nucleotide polymorphism.
Yeah, but I mean that every generation, like the small nucleotide getting.
No, that's something else.
Yes.
So, single nucleotide polymorphism means that in a particular place in a gene, for example, you may have a T and I have a G, and she has an A. But the gene is functioning normal. This means single nucleotide polymorphism. That's the definition of SNP. In SNP array, is just saying I can go with my markers till the level of one nucleotide. That's the only thing, right? That's why it's called SNP array. The resolution is so high that I can mark only one nucleotide. Okay. Other questions? For me or for Dr. Fouad? Okay.
Okay, I just wanted to ask, can you just clarify the karyotype technique?
Oh yeah, we can even open it again if you want. So it's extremely simple. So you need a biological sample where there are cells that are dividing, because only cells who are dividing are having nuclei, right? So, and the chromosomes are in the nuclei. And the chromosomes represent what? Highly condensed form of the DNA, right? Oh, that's okay. I will just try. Oh. Long things. You let me, I will find it. So I take the simple sample is blood, peripheral venous blood, and then I need to isolate the lymphocytes. Yeah, that's the image. No, first this, right? So when I need to reach a nuclei, and I need to make the nuclei to divide, because I know I can see the chromosomes only in a particular phase of a cell division. I will see nothing here in interphase, right? And neither in early prophase, but late in prophase and in prometaphase, I can see them. So here I can see, right? In prophase, prometaphase, and metaphase, because later they will separate and I will not see them. I lose this moment. So then what I need to do, I need to take the cells with the nuclei, lymphocytes from peripheral blood, and I need to put them in an environment who is resembling the human body. Otherwise, the cells will not divide. In your blood, the lymphocytes are permanently dividing, right? Your bone marrow is producing new ones, and so and so. So I put them in an environment here. It's called cell culture medium, who has a lot of nutrients who let the cells to grow. And then I have to put something that is stimulating them to divide, because in the body, they divide based on a specific clock, right? They have their own rhythm. But outside of the body, I need to tell them, now you can divide. So then I put phytohemagglutinin that is blocking then the division in mitosis. And then I'm here, right? Then I will be here, right, in mitosis, and I will be able to, I stimulate them to grow, and then I let them to grow for about 72 hours, and then I block them with the colsamide in metaphase. Now, when I block them, I need to be very smart. So they grow, and now I block them in metaphase. Then how I will analyze them? So inside in my medium, I have 100,000 lymphocytes who divide it and who are blocked in metaphase. But I have a small amount. I may have 5 ml, 10 ml, right? I have thousands of cells who are overlapping there. So how I will be able to analyze? Smart way. I am centrifuging to concentrate as much as I can. Then I have to put a substance who is making the cell to blow, right? In order from the nuclei to let the chromosomes to disperse, because they are overlapped. So if they are overlapped, I cannot count them, I cannot analyze them, right? So I come with a potassium chloride hypoosmotic solution. Then the cells will accumulate water from outside, right, through osmosis, and they will blow. Okay, now I have the cells blowed with a lot of nuclei, chromosomes inside. If I start preparing them, I will destroy the cellular membrane, the nuclear membrane, and I can create errors, right? So then what I need to do, I need to stabilize the membrane of the nuclei so it will not break when I start prepare it, but will break only when I want to be broken, right? So then I come with a fixative that it's fixating the nuclear membrane. And then again, I'm centrifuging to concentrate in a small amount to have many cells to be able to analyze. And then I'm pipetting on a slide. Now, this is a trick in cytogenetics, right? That's not something that you need to know. It's like the skill of each profession. A cytogeneticist is always using very cold slides, right? And wet slides to make the cells to slide, right? And to disperse on the slide. Then it's very important from where I drop it. If I drop it from here, it's a high gravity. When they reach the slide, they will disperse too much. And when I analyze, I will see 43 chromosomes. And I will say, oh my God, or 45. This patient has this and that. And if I put too close, it's low gravity, and they will not break, and they will be overlapped. So it's based on expertise. Only a cytogeneticist knows which is exactly, by trying an error, which is exactly the right height when you drop it, the cell membrane is opening, the nuclear membrane is opening, but then I can have separate cells. And I know this nuclei has these chromosomes, nearby it's a different cell, nearby it's a different cell, right? At this stage, if I examine on the microscope, I will see almost nothing because chromosomes look very, very, very light gray. I can see them, but if I give the slide to you, you'll see nothing because I train my eye and I know to do that. So what we do now, we need to fix the chromosomes on the slide. So we dry the slide on a heat plate, and then we color them with a color. Usually in cytogenetics, we use GIMSA, and GIMSA is creating dark pink, right? And then not only I color them, but I need to digest the proteins because, as we said, DNA, it's coiled by proteins, right? Histones. And I need to go in structure of the chromosome, so I need to digest them. So I use trypsin, and trypsin is digesting the proteins. So therefore, when I have GIMSA and trypsin, I will have a row of, multiple rows of bands. And we know now that each chromosome has different genes and different amount of DNA and heterochromatin, right? So each chromosome has a different pattern of bands. And having that, I can say for sure this is chromosome 1, right? And this is chromosome 2, and this is chromosome 15, and so, right? Of course, not at this level, but I show you later on, right, how images are looking. Initially, we just color them in GIMSA. They look dark, very dark pink, but then when you photograph them black and white, they look black, right? But then we use GIMSA and they look like that. Again, when you capture them on the microscope, they can look pink, or depends on the filter what you use, right? Black on white, right? So then I use the map, the ideogram the scientists and cytogenetics made, and said, chromosome 1 of this resolution shall has this kind of patterns, chromosome 2, and so and so and so. So then I compare this with what I obtain, where I am, here, right? And now we have automatic systems who are having the map embedded in the system. On one icon, you see the map, and on one icon, you see your metaphase. And you can verify chromosome by chromosome. And then you can say, it's easy to count them. The system can count for you automatically if they are 46 or not, but you can count with your eyes, right? And then you compare the structure. So usually, all this effort of coloring them and bending them, it's for structural abnormalities, because if it's numerical, it's easy to count them, right? It's also important to know what chromosome it's in plus. Sometimes it's difficult to differentiate 13, 14, 15, 21, 22. So it's important to bend them also to know that it's sure 21, it's not a 22 that you see. But you also know that trisomy 22 or trisomy 15, it's never compatible with survival. And if you have a sample from an alive individual, couldn't be only trisomy 13 or only trisomy 21, right? Clear? Other questions? It's just the principle. I need the cells who are dividing. I stimulate them to divide. I block the division. I concentrate. I fixate them then to avoid breakage. Then I put it on the slide. I dry them. And then I color them with GIMSA and with trypsin. I have the bands, and I examine on the microscope with the soft. That's the principle. Nobody will ask you how to, how to do in details, because that's cytogenetics. Yeah.
So for enough entrance is when the disease skips a generation.
Yes.
But for variable expression, or it's like when the symptoms are variant in a single generation, like it could be severe or mild in a single generation.
Yes, but this is linked with monogenic disorders, and you learned this in Unit 4 when we discussed about monogenic disorder more, right? This was more into the chromosomes. I just gave an example when you appreciate the recurrence risk, to know that in genetics, risk vary according to the type of disorders. Again, in chromosomal disorders, the risk for all of us to conceive a child with a chromosomal disease is 2-3%. The risk, it's increasing according to maternal age for aneuploidies, but has no correlation with the maternal age in structural chromosomal abnormalities, right? But in any chromosomal abnormality, the risk, it's there, 2-3%. If there is a translocation, the risk can grow to 10-15% or even 100%. If it's a monogenic disease, if it's recessive like is sickle cell disease, the risk is 25%. If it's monogenic like is Marfan syndrome, neurofibromatosis, and others, the risk is 50%. How to say roughly, because vary from case to case. And you learn that, how to appreciate, how to draw pedigree, and how to appreciate this, right? In polygenic multifactorial disorders, like, for example, diabetes, hypertension, cancers, or disorders linked with congenital abnormality, a heart defect, a person with one kidney, a person with 6 fingers on only one hand, yeah, the risk is again 2-3%, right? A bit similar with the chromosomes, right? Other questions? Fish, it's very simple, the same like the chromosomes, but when you have the slide, you don't color them with GIMSA, you don't treat them with trypsin, you come with a probe who is colored with the fluorochrome. And again, by complementarity, they bind. And if the probe is there, that means there is no deletion or duplication. If it's missing, there is a deletion. If you see two signals, it's a duplication. That's the principle. So fish, it's for structural chromosomal abnormalities. And array, again, it's for structural chromosomal abnormality. Fish is when you know clinically what kind of syndrome you suspect. Array, it's when you do not know, and then you look to all of them in details. Okay? And now the trend, we don't really do fish, extremely rare. When the clinical phenotype, it's so straightforward, it's no need to go to do an array. An array, it's more expensive and more laborious. If I'm convinced, for example, that the person has, I gave you in the image, there is a deletion of the chromosome 7, and this is Williams syndrome. You learn in the clinical years. Williams syndrome means a person who has stenosis of the arteries and has high blood pressure as a childhood, in childhood, right? Usually high blood pressure, it's after the age of, 30, 40, 50, right? But you may have a child who is the age of 5 and has really high blood pressure and has some particularities of the face, a lot of flexibility, right? Laxity of the skin and so, and it's coming to emergency because of a high blood pressure. And then when you send it to the cardiology, because it's not normal of this age to have this, right? They check the kidney, they check this, and they also check the heart, and they see that there is a stenosis of the arteries, right? And then it's because of a deletion on the chromosome 7. So then I know it's Williams syndrome. And then I will ask the lab, do fish for chromosome 7. If I don't know, I send for array. You do karyotype, but karyotype, it's only for numerical, right? And very big structural abnormalities. And these are quite rare, right? You do first karyotype. If you don't find anything, it's either you go for fish if you know exactly where to look. If not, you go for array. And nowadays, we do high-density SNP array. This is the latest one.
And it's meant for
30, okay? I don't know which was the slide 30. Okay. Yeah, you shall know. You shouldn't know all regions, but you should know how you 30. Oh no, that's just for example. This is just for you to understand where the science reach now and why it's important to diagnose in detail a deletion or a duplication, because it's, as I said before, if there is a deletion exactly here, I know what disorders are linked with this fragment, and I will know what exactly my patient will develop. So that's very important for the management and surveillance of the patient and treatment. So nobody knows this by heart. We all look on the maps. It's just as an example. Yes, the chromosome structure you shall know in this way, right? You shall know this. All chromosomes are having the same structure, so with small variation. So a chromosome has an upper part. I think the other slide is better, right? So there are 3 categories of chromosomes. Metacentrics, where the upper part is equal with the lower part. Submetacentric, where the upper part is shorter than the lower part. And acrocentric, where the upper part is almost absent. That's all. And what you need to know is this, because you need to be able to read us a formula. The upper part is P, the lower part is Q. The first number, 1, it's the region. The second number, it's the band. What it's following after the dot, it's subband. Nobody will ask you to know the bands and subbands of the chromosome, of any chromosome ever, because we don't know that. We look on the maps too, right? But we want from you to be able to read a formula, because as doctors, you receive reports from the lab with a cytogenetic formula. So you shall be able to read it, to understand what the lab wanted to write. Ideally, in the report, you'll have a description, but even though you are the clinician who have to deliver this report back to the patient, so you shall be able to explain, right? So therefore, remember in the other lecture, I put for you a lot of explanation and a lot of examples to play with here, right? Classification of chromosome abnormalities. Just to do exercises how you read. Remember that I put you some formulas. Yeah, like this. How I read it. 46 chromosome, a female, deletion on the chromosome 16. Where is the break point? On the arm, long arm Q, region 1, band 3. It's not 13. There isn't 13. 1 means the region, 3 means the band. And where is the other break point? Long arm Q, region 2, band 2. So the fragment in between was lost. Right? So you shall be able to read it. So if it was lost, I will check in the databases which genes are inside, so I can know exactly what my patient will develop. Because the genes are missing, those functions will not be accomplished. Yeah, makes sense? And like that, I put other. It's just for you to read it, right? Nobody will ask you to memorize anything, because nobody memorizes. We use databases and maps. And I put here the same, duplication, and I show you where the duplication is, to be able just to read it. Yeah? And to say if it's balanced or unbalanced. If it's a deletion or a duplication, it's always unbalanced. Huh? Any other questions? No? Everybody happy? Any questions for Dr. Fouad? Did you get all clinical data, as for sure he explained brilliantly, and also the ethics aspects that are so important? And the ethics are also linked with what Dr. Samira just explained. So please try to prepare your mind from now as students till you'll finish and you'll become, hopefully, brilliant doctors, as we aim. That medicine, it's not only about putting a diagnosis and writing a prescription. It's much more beyond, right? And if we all are so lucky that we've been born healthy, in very good families, and we had access to brilliant education, then it's your duty to help others who hadn't this privilege, right? And rehabilitation, it's a huge issue now in the modern era. These people deserve attention, respect, and acceptance like any other people, because it was not their fault. They haven't done anything wrong. They're just born like that, right? So then if we have access to this amazing knowledge and we understand genes, genome, chromosomes, and all this tests, then what do we do with this information? If you just put a diagnosis and write a prescription, that's nothing. It's just the first step, right? You need to help these people navigate life, to help them being integrated, to help them being accepted. You know, nobody is perfect. You are in a university because your mental capacities are good, but it's not necessarily to finish a university to have a decent life earning, right? There are many, many people who are not finishing a university, and their role is very important. Who is making our bread? Who is taking care that we have water daily in our houses, electricity, and so and so and so? Who is making clothes and plenty of things, right? We don't need all of us to go to university. We just need all of us to be healthy, happy, and earn a decent living, to survive and to thrive, right? So please look through this way, through the knowledge that you learn, to other people who are not having the same privilege that you had, right? And help them, guide them. That's your role. It's not only I put a diagnosis, I'm a doctor, I put a diagnosis, I give you a prescription, and my role ended. Like years back, a student told me, what I else to do? I put a diagnosis and I gave a prescription. But have you ever thought how those parents are feeling having a child so severely affected, and they do not know which school to put and how to manage? Have you thought on that? Have you tried to be empathetic 1 second, to feel the pain and the trouble and the distress those parents are feeling it? It's much beyond, I am a doctor. If you want to be a brilliant doctor, think beyond knowledge, right? because the system, it's taking care perfectly for you to get the knowledge that you need. But it's up to you when and how you upgrade this knowledge and how you apply it. We will not be there to control how you speak with your patients and your families in the clinic, in the ward, how you behave with your colleagues will be you, will be your responsibility, right? So because some students complain in the past, why we need rehabilitation, we don't need this. Why we need this? This is life. This is life. You are healthy now, we may not be tomorrow, we never know. And we need to know about these services. And as doctors, we shall know where to recommend our families, patients to go, right? That's very important. So I hope that through all of us that presented in this problem, all these aspects, you learn something, that your knowledge is upgraded. And again, you see beyond the knowledge. And if you have any questions for us beyond what we discussed today, through the time that you prepare for the exam, feel free to drop emails to us. You have our emails and we'll be very glad to answer you, right? Okay? Good. Thank you too for your time.